All right, we're going to get started. So we're continuing our Controversies in Hepatology series. Dr. Da today is going to talk to us about the controversy around checkpoint inhibitors as first-line therapy for HCC, which is an evolving area where there's some evolving data. So we're going to go over some of that. So take it with them.
All right. So we're going to go first through introduction, some of the sorafenib and nivatinib data and the TKI data, and what we have currently available for phase 2 and phase 3 data for immunotherapy, and kind of like what's the future. So I'm going to run through a lot of clinical trials. A lot of this is a lot of the data is unpublished so far, but this is the most recent kind of paper data. I'm going to try to make it comparable, but it's very hard to compare clinical trials, I think, between each other. So introduction-wise, HCC is the predominant form of primary liver cancer. It's the 6th most commonly diagnosed cancer worldwide. It's the 4th leading cause of cancer death, and the numbers can vary from study to study. Highest incidence rates is in East Asia and Africa, making up about 85% of cases, and the 5-year survival is about 20%. So the global prevalence of HCC, this is the graph from Augusta Villanueva. The highest incidence you see is in kind of Asian countries and then in kind of Central Western Africa. Surgery traditionally has been the most successful treatment for HCC, either through resection or transplantation, but it really depends on function, portal hypertension, burden. And local regional therapy has really been like one of the main alternative therapies. And we use TACE a lot, we use the Y90 ablation a lot. But recurrence is common, especially when the liver is cirrhotic, and so then patients present with more aggressive disease. So this is kind of the BCLC class that we're all familiar with, and we're really going to just focus on class B and class C, the intermediate to advanced stages. And you'll see that most of these clinical trials, they involve patients from both B and C, not necessarily just C. And the definition, inclusion criteria for each trial are just a little bit different. So it's very hard to compare these clinical trials. But I just want to define advanced stage as having macrovascular invasion or extrahepatic spread. And really the prognosis is very different between the two stages. So this is an older chart. This is from the ASLD guidance from 2018. So we're really looking at the two stages here. They don't have pembrolizumab on this graph. I think it hasn't come out yet, but you'll see that the level of evidence at that point on nivolumab was kind of stage level 2. And for the advanced stages, we're really starting with more of the TKIs first. So advanced HCC, so I think the definition is different. It's kind of blend between BCLC B and C, and it comprises of the majority of patients who present, and really these patients are outside the eligibility for transplant surgery or LRTs, but from our purposes it's important because it's actually interesting to see what the oncologists will end up doing with them. So the available therapies we have are TKIs, so sorafenib and lenvatinib are approved for first-line therapy, and regorafenib, cabozantinib, and ramucirumab are for second-line therapy based on the AFP. So immunotherapy can be used either by itself or in combination in a clinical trial. So the two that have conditional approval are Nivo and Pembro. And then I think some of the chemotherapy regimens like FOLFOX are in the back lines, and then combination therapy are used in clinical trials. So this is a kind of a treatment algorithm that was just a couple of years ago, and they actually, when you look at the kind of the left-hand side for BCLC B and C, they actually recommend either sorafenib or lenvatinib or a clinical trial with a checkpoint inhibitor, and then second-line therapy, and then third-line therapy. So this is kind of the diagram. So the two that are kind of have the accelerated approval are Nivo and Pembro, and they're PD-1 antibodies. And the PD-L1s, the durvalumab, atezolizumab, have not during clinical trials, but they haven't so far, aren't widely used for HCC. And so are the CTLA-4s are all in clinical trials and haven't been approved yet. So when we run through these clinical trials, I want you to pay attention to a couple of things. First, the objective response rates. So the objective response rate is a combination of the partial response plus the complete response. and disease control rates, which is different because that adds on to like the disease stability, duration of response, and they usually do this as a median duration of response, or how many people respond for greater than 6 months, or 9 months, or 12 months. Progression-free survival, overall survival, adverse events, and so we're looking at treatment-related adverse events greater than 3 or 4, so 3 or 4, and these are the serious events. And then how many of these events, or how many of these medications lead to treatment discontinuation in these clinical trials. So these are the things you have to pay attention to with each of these trials. So the TKIs, this is again from the guidance on the 5 that are approved, and the 4 that are approved, and this doesn't have ramucirumab. They all have hazard ratios between 0.63 to 0.92. The lenvatinib one is a non-inferiority trial with sorafenib, so just to be aware of the various TKIs that are approved. So just to start, I think every one of these presentations have to start with this phase 3 from the New England Journal data from 2008. So this was a phase 3 trial here, sorafenib, placebo-controlled sorafenib versus placebo in patients who had not previously received systemic treatment, so first-line therapy. Their definition of advanced disease was people who are not eligible or had progressed on surgery or local regional therapy. Their inclusion criteria will pretty much be the same for all these trials, a little bit like different, but mostly they're all child A. They both have higher like life expectancy more than like 3 or 4 months. Not very advanced liver disease, as told by their Billy and the INR. So in this trial, pay attention to the median survival. So sorafenib had a 10.7 median survival, the placebo had 7.9. So it's a 3-month edge, but this is a good baseline to compare the immunotherapy treatments to. So first-line therapy, advanced HCC, sorafenib had about a 10.7 median survival. Their 1-year survival was 44%. Time to progression was about 4 months. And the complete response is almost nobody had a complete response. Partial response, almost nobody had a partial response, 2%. And stable disease was 71%. So their disease control rate was 43%. So, so just remember these numbers when we look at the other trials. So really, sorafenib is the therapy that's really aimed at delaying tumor progression, not to really like kind of evaporate tumor.
And do you know the underlying disease etiology?
I think it was a mix.
It was.
Yeah.
Because just when we're trying to compare trials, I think one of the really important things to compare are the people in the trials.
Yeah, I think, I don't remember the exact proportion of Hep B, Hep C. So the Kaplan-Meier survival curve does separate. It is significant. But if you look at who responded, the people with extra hepatic spread, really like the hazard ratio crossed 1. So the people with extra hepatic spread, like there's no difference between placebo and sorafenib. And if you lump the macrovascular invasion with the extrahepatic spread, it almost crosses 1 with hazard ratio that tipped over at 0.99. So people with really advanced disease, extrahepatic spread mets everywhere, the sorafenib didn't really make a difference with complete to placebo. Yeah, it might not have been significant. So this led to some phase 2 data. This is on lenvatinib in advanced HCC. And I'll show you the follow-up trial. You look at the kind of the complete response of lenvatinib, about partial response about 37%, stable disease 46%, objective response of 37%. Which is much higher than what you were seeing in the data. But this is phase 2 data, not controlled, small number of patients. But a disease control rate of 83%, which is really high. This was from a study from Korea and Japan. So this led to the phase 3 data, which was a randomized non-inferiority trial between lenvatinib and sorafenib. Open label. Their definition of advanced disease was a little different. So their definition was just unresectable HCC. So I thought these patients might have had HCC with a little bit less advanced disease. Anyways, if you look at the comparison group, overall survival was much higher even in the sorafenib group compared to the previous SHARP trial of 12.3 months compared to like about 10 months. But lenvatinib was 13.6 months. This was not significant, but you do see kind of like a trend towards improvement. Sorafenib with a progression-free of like around 4 months, lenvatinib was 7.4 months, and then you see like kind of higher objective response rates of 24.1% in the lenvatinib group compared to only 9.2% in the sorafenib group, which is still much higher than what it was in the SHARP trial.
Although remember the SHARP trial was using RESIST,
Right.
not
And then for stable disease, about the same. And about a third of patients had kind of a lasting duration of response for both drugs, for greater than about half a year. And overall survival. So looking at the curve, it was not different, but almost parallel, but you do see kind of like almost a trend towards improvement with the lenvatinib group. Looking at the adverse effects, this is a good trial comparing the adverse effects. You see that I think what you're looking at is the second row, which is treatment-related, treatment-emergent adverse events of greater than 3 or 4. About 50% in both groups developed some sort of major adverse event or adverse effect from the treatment with both drugs. And then almost 10% in each group led to treatment discontinuation. It's pretty high. And then so the treatment adverse events in the lenvatinib group was mainly hypertension, diarrhea, weight loss. In the sorafenib group, it was mostly palmar-plantar erythrodysplasia and diarrhea. So a summary, it seems that TKIs prolong survival, but may not be helpful with patients with more advanced HCC, such as METs. Very low rates of partial and complete response depending on the patient population and how the trials were done. Prolonged response for about 6 months in about a third of patients with stable disease, and very high rates of high-grade adverse effects related to the treatment, nearly 50%. So looking at immunotherapy now. So immune checkpoints are T cell surface molecules that can inhibit or stimulate the immune system, are responsible for maintaining self-tolerance and preventing unwanted immune responses. So PD-1 is a self-service protein expressed on a lot of T cells, and when upregulated following activation of T cells, binds to PD-L1 and inhibits effector T cell responses. And CTLA4 is another membrane molecule that serves a key role in kind of controlling the immune response by Tregs. So should immunotherapy be used as first-line therapy in advanced HCC, given we kind of see kind of like a moderate amount of response with TKIs? So this is the phase 2 data, the Checkmate 040 trial, which is an open-label, non-comparative trial, phase 1 and 2 that we've all seen before. There's a dose escalation phase and a dose expansion phase of 48 patients and 214 patients. This is an interesting trial because one of the groups with 56 patients with the arrow points at it had sorafenib untreated or intolerant patients. So these patients were really first-line therapy, and they were mostly sorafenib untreated patients. So this is important because it leads to a lot more like confidence, I think, that you can use Nivo as a first-line therapy. So, so this is the two columns. So one is the 56 with mostly untreated untreated patients, and then the rest of the cohort of 214 patients. The full data is not published yet, but the overall survival about 13 months. And this is including a lot of patients in the second-line therapy, so mostly better than the sorafenib data, even though a lot of the patients were second-line. Objective responses were 20 to 23%, which is pretty high compared to the sorafenib data. Complete response about the same. Partial response is higher than the sorafenib data. Stable disease is higher. Duration response was, even though it wasn't really reported in the sorafenib data, seems very high at like 9.9 months, 8.4 months. And disease control rates, 64 to 75%, pretty high. And then a disease control for greater than 6 months, about 40%, and overall survival 9 months of 80 to 70%, which seems pretty high, and a very low rate of grade 3 to 4 adverse events, only around 25%. And it seems to be a lower rate of drug discontinuation. So it seems like very encouraging data. And based on this, they got the conditional accelerated approval in 2017. So this was a kind of a diagram that shows, I want to pay attention to this group, which is the untreated or intolerant. So it's mostly untreated. They had a pretty much similar response to the people who were sorafenib progressors in terms of how long they responded and so forth. So that was interesting because it shows that it can probably be used as first line and second line. Probably there's not much of a difference. And then they also had, there are some patients who, on the top, they responded for a really long time. Some of them responded for like 36 months. So it shows that the duration of response for these immunotherapies can last for a very long time. Something that we don't really expect with TKIs. So then in the next trial, this was a second line trial, but also shows kind of a similar thing. This was from pembrolizumab Keynote 224. Getting pembro, all patients got pembro, through class B or C, and it was non-comparative. They had 104 patients. Their overall survival in the second line setting was about 13 months. Objective response about 17%, pretty similar. Partial response 16%. Duration of response wasn't really reported, but went up as high as 14.6 months in their upper limit of confidence. And disease control for greater than 9 months of 77%, which is very high. And treatment-related adverse effects 25%, which is similar. Very low rates of drug discontinuation. So both drugs got conditional approval based on these data in 2017 and 2018, based on really phase 1, phase 2 data. So the phase 3 data came out for nivolumab in June. This is a press release. The full data hasn't been published yet. Of the phase 3 data from 743 patients, nivo versus sorafenib as first-line therapy for unresectable HCC. Pretty similar inclusion criteria. Their primary endpoint was not met. P-value was 0.075, but you do see like a trend towards improvement with the nivo group. Hazard ratio is 0.85. But the key thing that I think most of these people running these trials is making is that 20% of the sorafenib group crossed over and got immunotherapy later on, which would affect the primary survival, overall survival. And they also make the argument that these patients who got sorafenib first actually sensitized these patients and made them actually respond better if they crossed over later and got the immunotherapy group later. So they may have even responded even better because it's kind of like a combination group. So the data becomes very hard to interpret, and it's kind of unethical to make them not cross over. So the overall survival is very difficult to meet. But the overall response rates was double from nivo compared to sorafenib. And if you're looking for a complete response, 14 patients in the nivo group had complete response versus sorafenib, which is almost triple. So if you're a patient and you want complete response and just wipe out all the tumor, then it seems like you would head towards nivo. If you're kind of like aiming for this home run. And safety-wise, much better with the nivo group. But the full results have not been published yet. So Keynote 240 was the phase 3 trial looking at pembro, and this is in the second line as well. 408 patients also didn't reach survival significance with either overall survival or progression-free survival. So you're starting to see a trend, especially with this with these immunotherapy drugs. So this is just a meta-analysis looking at the safety. Pretty consistent what we're seeing with the clinical trials. So at 14% of patients from like 110 studies developed at least one grade 3 or higher adverse event, mostly fatigue, itchiness, and diarrhea. But in the most common event was really fatigue and anemia or mild AST elevation. And it seems like nivo was associated with a higher grade of adverse events compared to pembro. So looking at the pros and cons, if you argue for primary immunotherapy, the pros are it's less toxic. It's about twice as less toxic, less treatment discontinuation, much better response rates compared to sorafenib, but maybe not lenvatinib. Longer duration of response, but no difference in overall survival, and this is because probably the design of the clinical trials. Similar really cost and similar response rates and duration of response regardless of when it is used. So you can make that argument if it responds well in its first-line therapy and second-line therapy about the same, then you can really reserve it as a second-line therapy and give them TKIs for this like sensitization kind of process.
Combination therapy?
Yeah, so the combination therapies I'll go over in a little bit, but there are several of them in phase 3, like the CTLA-4s with the PD-1s, and there's combination therapies with TACE plus immunotherapy, kind of just to like kind of blow up the tumor, release the antigen, I think, in a way, increase sensitization. But the results are not published yet. There's some phase 1 data that shows that it's very encouraging.
That first line treatment trial, do you know if it was powered as a superiority trial or just
For which one?
the nivolumab versus?
It was superiority. So some special circumstances that affects us is in the post-liver transplant setting, we really don't know. Underlying autoimmunity, patients with mixed tumors. So these are all the phase 3 trials as of, I think, last year that were in progress. There's CTLA-4s with PD-L1s. PD-1s, there's combinations of VEGF inhibitors with PD-1s. So a lot of things in the pipeline. I think that will come out in the next few years. I think the future for this advanced HCC will probably be in combination therapy somewhere to kind of just build synergism based on these treatments. But the question is, if you use combination trials and the patient progresses, can you go back to one of the kind of the constituents as like second line therapy? I don't think really anyone knows. So these are some of the things in the pipeline. They include like vaccines, peptide vaccines, CAR T. These LAX3, TIM3 are all checkpoint inhibitors. Combination therapy, CTLA-4s. So a lot of different like cytokines, vaccines, adoptive cell therapies that are in the pipeline, but a lot of them are very early on. So this was an open-label phase 1 study looking at pembro and lenvatinib, so a combination of TKI plus the PD-1. Only 30 patients, but there was a complete response about the same, but the objective response was 36.7% to 50% with the combination therapy, so much higher than what we were seeing with each therapy by itself. So in summary, the overall survival in HCC groups comparing TKIs to checkpoint inhibitors are difficult to interpret due to the crossover. But the factors favoring checkpoint inhibitors include duration of response, high response rates, disease control, and less toxicity. And combination therapy is likely the future of advanced HCC treatment. Some of the questions are, will biomarkers-driven therapies, such as like for precision medicine, change the treatment landscapes? And some of these trials did look at the like PD-1 percentage, but really didn't find anything conclusive. And if immunotherapy is used in the first line, well, would the choice be for second line therapy? And we have a lot of things that are approved just for second line therapy, but would you use something that's approved for first line therapy as second line, such as sorafenib or lenvatinib, in the second line if you progress on primary immunotherapy, first line immunotherapy? And then would drugs be used in preference to chemotherapy or TACE in the intermediate? What drugs would be used in preference after chemotherapy or TACE in the intermediate HCC setting? And will both efficacy and safety be crucial to ensure approval? Both of these drugs are kind of conditionally approved at this point. That's it.